जमा किए वो
लिया नहीं, बोला पूछा तुम्हें था। कीबोर्ड है ना, माउस है ना, माउस है लगे कहाँ पे, तो कोई नहीं, जो है वो दे दो, कोई दिक्कत नहीं।
Welcome, Shri Vishal Chauhan ji, Joint Secretary Policy, Ministry of Health and Family Welfare. I welcome Dr. Pradeep Khasnobis, sir, who is yet to come, DDG, Ministry of Health and Family Welfare. I welcome Dr. Major General Professor Atul Kotwal, sir, Executive Director, National System Resource Center, as a chief guest. Without further ado, to give a warm welcome to esteemed dignitaries for the inaugural session, I would like to invite Dr. Madan Gopal, Advisor, Public Health Administration, National System Resource Center.
Thank you. Good morning, sir. Good morning, dignitaries on the dais. It gives me an immense pleasure because this is my maiden first dissemination workshop in NSHRC. So I'm very honored to do this thing, to take the baton forward, the work done by the team and the guidelines and other things which have been developed earlier. So I'm very honored to take this thing forward. I take this opportunity to welcome the Joint Secretary, Mr. Vishal Chauhan, for taking his time and blessing this occasion. I'm grateful to our Executive Director, Major General Kotwalji, who has been always been guiding force behind all such events and this workshop, organization of this workshop. I'm welcoming all the experts who have joined and who have also contributed to the development and evolution of these guidelines. And there are many people from the states who have joined online and the people who are viewing this on YouTube Live. So we welcome all of you. It shows the importance of these guidelines, why these guidelines are required. We have always been talking about the sustainable development, achievement of sustainable development goals by 2030. And to target that achievement of the sustainable development goals, we require to have something for the emergency and trauma care services. And these guidelines, operational guidelines, will be very useful for building capacities at the district and the sub-district level hospitals. With this, I invite the other esteemed speakers to speak on this occasion. And Ashutosh, please continue from here. Thank you very much.
Thank you, sir. May I now request Major General Professor Atul Kotwal, sir, Executive Director, NHSRC, to kindly address the august dignitaries in the House and those who are present online. Thank you, sir.
Thank you, Ashutosh. Good morning, everyone. Shri Vishal Chauhan, Joint Secretary Policy, Ministry of Health and Family Welfare, Dr. Madan Gopal, Dr. Himanshu Bhushan, ex-advisor, PHA, all the other experts. I'm not taking the name of everyone. I know a lot of you personally also because of the time as such, but it gives me immense pleasure. The launch of these operational technical guidelines on emergency care services at district hospital. And the credit goes to all the experts who have worked with us day in and day out. There's a series of meetings and it for us to finalize and then finally you are releasing it today. And a credit for all this goes to Shri Vishal Chauhan, Joint Secretary Policy, who us in all when we try to think beyond what is being routinely done. So it is time now, we all know, I'm not going into details of, I must also come and thank as ADNHSRC, all those who have joined us online. Here later on, subsequently, we have joined online, the number with everyone, all of us. And starting and all the social media and all, there were a lot of likes for this, the dissemination today. So that means community, the people are looking forward to such guidelines because we all know the triple burden we are facing. The reproductive maternal neonatal childhood, the low research agenda as such, unfinished agenda, the communicable and non-communicable, of course, especially COVID has shown us emerging and re-emerging diseases and the non-communicable diseases. So the emergencies which are being presented now, there's a lot of load on tertiary care because of the paucity of beds and the specialists and the critical care which is available at the secondary level. And another important issue is the linkages with the primary care. These guidelines will help the district hospitals which are already on way to being energized as such, and now with critical care blocks coming up under the PMO and Finance Commission grants. So we will have the strengthened district hospitals to take care of all these emergency care services, which includes the non-communicable disease emergencies as well as communicable disease emergencies, and what we should not forget, the road traffic accidents. In fact, I was in one of the states last week where young DC was discussing with me that they need a lot of units near the highways because the number of accidents we are aware, and the roads are becoming better and better, speed is increasing. And the accidents and the morbidity and mortality both because of that, and the golden hour principle because of the services which are not available at each district hospital. So that is why these guidelines will help us in strengthening those. The guidelines include the requirement of infrastructure, human resources, the service provision as such, which is most important, quality and patient safety, So it's a comprehensive guideline which not only the district hospital, private as such of the similar size hospitals will be definitely able to use these guidelines to strengthen their medical setup, which of course the government of India under the and also otherwise it available to the community at large. With this, I think I'll stop here. Forward to the deliberation subsequently. But word of thanks, not my this is the subsequently. But I must thank JS Policy for his continued support and guidance in all our endeavors as such. The previous PHA advisor, Dr. Mansulushan sir, the current advisor, and of course all the experts who have worked and the PHA team of the team. All of them are here. It's a lot of hard work by the PHA team also. And once again, congratulating the PHA team for the culmination of this and we reach the final stage today. Thank you very much.
Thank you, sir. We welcome Dr. Pradeep Khasnovis, sir, DTG Ministry of Health and Family Welfare, and we will request sir to kindly give us address.
Hello. Yeah. Good morning, all. I would like to say sorry. I was a little late, stuck up in the ministry because of this forthcoming cyclone that is hitting Gujarat. So there was some discussion going on with over there. Yes. So those are some of the really challenges what we face. So let me just come to the discussions. Respected Chauhan sir, respected Kotwal sir, I see a lot of friends, senior faculties who are sitting in this room. Respected all. So let me just like to congratulate first and foremost for this wonderful guidelines where we were also given the opportunity to contribute the operational and technical guidelines on emergency care services at the district hospital, because that was the need of the hour. The reason being, there is a substantial rise in emergency related deaths over the past decades. If we look into the figures, the daily figures in the CRO countries, there are 90% of the deaths that has been reported because of this. And this has also been highlighted in the SDGs also. So looking into the dual need of the hour, we need to concentrate on this. This operational and technical guidelines for the district hospital have been formulated basically because I was part of the team with a key objective to develop an integrated emergency care services system at secondary care level that can be comprehensively addressed to all types of medical, surgical, trauma-related activities. And the role of emergency care service has significantly evolved with advances in medical care and technology, and now encompass a broader range of responsibilities, including pre-hospital care, assured referral transport with intra and intra-facility transfer, linkages with the critical care blocks, along with in-hospital treatment. This is an important provision of seamless and uninterrupted service throughout the continuum. This guidelines also aims to strengthen the secondary level services by providing infrastructure, human resources, essential drug lists, because these are some of the basic things. Whenever there is an emergency or something, or like a disaster situation, there are certain basic parameters that we need to see of our preparedness. So this guidelines will help the district hospital to be prepared in a better way. And to add to this, because at this juncture, I'm working at the disaster management cell of the Ministry of Health and Family Welfare, we are also doing some of the endeavors in equipping the centers. Like we are also having a course which has been formulated through this August House. I see some of the prominent faces over there. We call it to be the National Emergency Life Support Skill Centers, which have been built in the medical colleges to train those district hospital doctors on the emergency management. So around 95 medical colleges are already enrolled into the system. And we are also hoping to get many more of them so that they can be part of the system. Along with it, we also are training the system, the doctors, especially the doctors who are working in the hospitals on emergency and trauma care, doctors who are working in the field, how to look into a disaster, the psychosocial management of a disaster care, because that is also something we should not miss. That is paramount importance. Then there is a specialized emergencies like radionuclear events. So there are capsular courses, 7 to 14 days of duration that has been run through this disaster management cell for the district people. We take nominations for the district peoples, and then there are institutes which are there, which are training them on these subjects so that they are fully accomplished to manage such kind of a disasters. And then I just come to that hope that these are some of the endeavors which Government of India, through different programs, different curriculums, different guidelines we are offering to the states, which the states would be utilizing to equip them in a much better way. So I hope the states would find these guidelines to be really useful, and I close over here. Thank you.
Thank you, sir, for impressing the need of an emergency care services in the country and parallelly the capacity building of our health work staff. Ladies and gentlemen, the need of the hour is here. We'll now begin with the release of our guidelines. I would request the dignitaries on the dais to kindly release our operational guidelines for operational and technical on emergency care services at district hospitals. I request my colleague to kindly support. Thank you, sir. May I now request Shri Vishal Chauhanji, Joint Secretary Policy, for his keynote address.
ED NHSRC, Dr. Professor Atul Kotwal ji, Dr. Pradeep Asnovis, in charge DM cell in the ministry, Dr. Madan Gopal, Dr. Himanshu Bhushan, and all the senior officers and the experts sitting in this room, and all the officers, medical officers and other senior officers from the state governments, doctors from the district hospitals and other staff from the district hospitals who have joined online. It is really a matter of great, proud and happiness that today we are started dissemination of the operational and technical guidelines on the emergency care services and district hospitals. They will also be useful at the CSCs, which are working very well and have good facilities to some of the facilities to handle these kind of situations. So first of all, let me congratulate ED NHSRC, Dr. Himanshu Bhushan, who put all the efforts along with the experts who are sitting here for multiple rounds of meetings, many rounds of discussions. And sometimes we also get the feeling that dissemination of these guidelines is more important than creating new guidelines. But Dr. Himanshu and ED NHSRC was able to convince ministry that it is very important, and we should draft these guidelines. We should disseminate these guidelines because we are aware that I am told that about 1.5 lakh people die every year because of the emergency in the country. And this is besides the other NCDs related emergencies like cardiac arrest or stroke, even the cases like snake bite, etc. There are a lot of deaths take place in the country. And it is very important that these issues are addressed in a timely manner. In the 72nd World Health Assembly in 2019, it was also emphasized that timeliness is a very essential component. Unless we are able to provide the assistance in a timely manner, for that we require infrastructure, we require equipment, we require skilled manpower who knows their job well. And what are the guidelines, how the triaging has to be done, how the emergency has to be attended, what to attend first, what to attend at a later date is a later time is very important. So I'm very happy that these guidelines have been prepared. And today we are having this workshop. We have also started a series of webinar for training of the medical officers. If you, many of you must be knowing that recently we had a webinar of about 2.5 hours on the non-alcoholic fatty liver diseases, in which about 9,000 medical officers from the primary health centers joined. And we had a team of Dr. Sareen, etc., and Dr. Vineet Ahuja from the AIMS, who talked about non-alcoholic fatty liver disease or alcoholic fatty liver. Basically, they talk about liver for 2 hours, and it gave a very fantastic orientation to the our medical officers. We have about 40,000 medical officers at the primary health centers, at the CSCs, and at the district hospitals. So maybe what we have decided is that every 15 days we will have this kind of webinar where we'll take a different topic. And I'm sure that one topic we have to take on the emergency care, where we'll have all the experts who are sitting here about 2 hours or 2.5 hours, and we disconnect medical officers. Today we are talking to the district health officers or district level officers or district hospital, those who are working at the district hospital, but we will also should have a webinar where we address the medical officers in a large number. And Dr. Khasnobis was talking about, the post-trauma mental issues and all. So I'm also very happy to tell you that now we have a telemana service in place. So far, we have received about 1.5 lakhs calls. On an average, we are getting about now 1,500 calls every day. So that is also one of the tools where those post-trauma mental health issues can be addressed. So I'm very happy that today we are having this dissemination workshop where we'll talk about the skills required, the infrastructure required, the human resources training, the drugs, equipments, etc. And also, I'm very happy that I recently visited 5 states: Andhra, Telangana, Odisha, West Bengal, and Gujarat. The work on the critical care blocks of the PM Abhim has really picked up. And these critical care blocks also will serve this purpose. Of course, they are basically meant that in case of a COVID like a situation come, then our routine hospital functioning should not get disturbed, and we have a critical care block which can handle COVID cases with a separate entry, separate exit. That also guidelines is made by NHSRC under the leadership of ED NHSRC and Dr. Bhushan at that time. So now they are coming up on the ground, and I'm very happy that but when the COVID kind of a situation is not there, so how we can best utilize these critical care blocks to address the cardiac emergencies or stroke emergencies or other kind of emergencies, how we can do a kind of a integration with the existing health system. Also, Niti Aayog, with the help of the AIMS, in which Dr. Madan Gopal was very keenly involved, has done a study of the total emergency and trauma care scenario in the country. So it has been found that there are gaps. There are gaps in terms of infrastructure. There are gaps in medical colleges. There are gaps in the district hospitals. In terms of infrastructure, our average ambulance rate, which is reaching at the site, is also 20 or 22 minutes. While in developed country, it is about 10-12 minutes in Europe, etc. So also we have to work on this. So there is also thinking going on that we have a separate scheme or the emergency and trauma care, and create a infrastructure, and increase the number of ambulance. But in the meanwhile, we continue to support under the NHM whatever critical care gaps are there. NHM has been supporting all the states in strengthening of district hospital, strengthening of CSCs. So that will continue, and I am very much hopeful that once these guidelines are understood by the team, next year in the PIP we'll surely get proposal which will make district hospital well equipped to handle these kind of situations. Whether it is hiring of some emergency technicians are there, or whether it is some training skills are required, or whether it is some critical equipments are required, we are always welcoming this kind of strengthening in the district hospital. So I wish this workshop all the best. I'm very much sure that if we listen to each and every expert here, it will really enhance our understanding and our knowledge on the subject. Thank you very much. I once ED NHSRC, Dr. Professor Atul Kotwal, and Dr. Madan Gopal for organizing this event. Thank you very much. All the best.
Thank you, sir, for your words of wisdom. Now I would like to request Dr. Ashima Bhatnagar for the vote of thanks for the inaugural session.
Thank you. Dissemination of emergency care services at district hospitals guidelines is just a beginning towards achieving assured emergency care services. And none of this would have been possible without the contribution of so many stalwarts. To start with, my sincere gratitude to Shri Vishal Chauhan, Joint Secretary Policy, for his stewardship, vision, commitment, and continued support in guiding us and taking the agenda forward. I'm immensely grateful to Dr. Pradeep Khasnobis for his overview and valuable inputs. Without the guidance and support of Major General Professor Dr. Atul Kotwal, ED NHSRC, none of this would have been possible. So thank you, sir. I can't thank enough Dr. K. Madan Gopal, advisor and head PHA NHSRC, for guiding us throughout, and Dr. Himanshu Bhushan, sir, former advisor and head PHA, for taking the first step and bringing us all together. I also thank all the experts and representatives who have joined us here and online for their active participation. And I must thank and acknowledge the efforts by entire administrative division of NHSRC. Last but not the least, I thank the team PHA division for their tireless efforts in making this workshop a success. Thank you, everyone.
Ladies and gentlemen, with this, we conclude the inaugural session. May I request our esteemed guests to proceed for tea and refreshments kindly. We'll be shortly resuming with our technical and panel session in 20 minutes. Group photograph. So we'll have a group photographs also. I request all the panelists to kindly also join us for the group photograph, please. we are taking a short break for tea and refreshments. We'll be back in within 20 minutes. who are connected online with us. We'll now begin with the technical session. I may now request Advisor, Public Health Administration, NHSRC, to give us an overview of an emergency care in India and also the salient features of the guidelines. I welcome you, sir.
कोई बात नहीं है तो क्या कर सकते हैं. जी हाँ ठीक ठीक. हाँ ठीक आइए सर. आज somebody तो नीचे है. Thank you, Ashutosh. Good morning. It's an immense pleasure to share the thoughts and share the emergency care services in India. So I would be just deliberating on that. Few of the slides I have taken from my previous avatar. So I would be sharing so that a continuous story is there why it is required. So a high level discussion is going on for creating an emergency level discussion, but I would be just restricting myself to the operational guidelines which are there. So next. So we all know that we have a huge burden of emergency and trauma cases in the country. Every year, India sees around 6.5 lakh road traffic injuries. 5 lakh are injured and 1.5 lakh die, often young and bread earners. This causes a loss of GDP to around roughly around 3% per year. Not to talk about the disability life adjusted years. That is also a huge problem here. Similarly, around 2.5 million heart attacks happens every year, resulting in 2 deaths per hour. Chronic lung disease and stroke afflict 55 million and 7 million people, often presenting as acute emergency conditions. In addition, 60,000 cases of snake bites, 26,000 poisonings, 1.4 lakh suicides, and 0.4 million newborn deaths are reported every year in the country. If you look at the emergency and trauma, we have to think it as a priority because right now the emergency services, there's a one fraternity which talks about emergency services. There's another fraternity which talks about the trauma services. So we have to take both the things together and treat it as a priority. The emergency conditions trigger unexpected out-of-pocket expenses. If you look at the NSSO data, the 2 rounds which have happened, the previous round it was 72%, now it has come down to 78%. But to avoid any catastrophe due to any health events, the target is to reduce it by less than 25%. So still a long way to go to make a dent on the out-of-pocket expenses. The optimal emergency and trauma care demands time-sensitive integrated health system that functions 24/7. This is a severe challenge, and in the subsequent slides, you will appreciate that why I am saying this thing. Then improving emergency and trauma would contribute to multiple SDG targets. We have multiple SDG targets. One of the target is SDG 3.1. I think reducing the number of road traffic accidents by half by 2030. So a long way to go because we don't have actual figures to how many road traffic accidents are happening in the country. If you look at the emergency trauma system, the WHO has given this framework. Okay, how does a emergency ecosystem look like? One is on the scene, that is first responders, then the transportation, and then the facility. We have to see that when we are talking about an ecosystem, how we are able to address all the issues right at the site or the scene, right at the level of transportation, and third is at the facility level, right from the capacities and the facilities. All the things are required. And the guidelines which we have released today, that more or less encompasses the requirements at the facility level. Then if you look at इसे लैग कैसे आ रहा है इसमें? If you look at the, as Jay sir has mentioned, during my previous avatar in Niti, I was associated with the AIMS team with Dr. Boy, led by Dr. Boy and his team. We have facilitated a study to study the gaps of the emergency care system in the country, where they have studied 100 secondary care institutions, 100 secondary and tertiary care institutions, as well as 34 district hospitals, about the gaps in the emergency care systems. So this is having a pan-India representation. In this study, they have highlighted gaps in the infrastructure. At the medical college level, where the sample size was 100, they have found that 45% of the medical college don't comply to composite essential infrastructure requirements. Whereas at the district hospital, 33% of the district hospital don't have emergency rooms. In addition, there are two key infrastructure which were lagging. Area for triage in 94% of the district hospital studied were lagging. Required number of beds in the emergency department, 50% were lagging. In 47% of the emergency department, the earmark areas were lagging. The emergency OTs only 30% were lagging, and point of care labs in majority, that means 94% of the emergency department, they were lacking point of care labs. If you talk about how prepared we are in terms of the infrastructure, if you look at the ambulance services, most of the things are happening through in-house ambulance services, the 108 services which are there. We have invested a lot into the in-service ambulances, and it has taken slowly and slowly. You do see the presence of 108, but is the density sufficient? Do we have trained paramedics to handle the ambulances? Because the first responders, that means from the scene to the scene transportation and the facility, is in between care that is more important. Do we have trained paramedics? Only 3% trained paramedics are there. Look at the emergency department beds, triage facilities, access for ambulances. Though we have the ambulance services, the response time with Jay sir was mentioning, it varies. In the difficult areas, normal response time has to be less than 20 minutes. But are we able to reach that thing in 20 minutes? So in the peri-urban areas, the task is there. But if you talk about Delhi and that kind of metros, are we able to meet that requirement or not? So you have to see, these are the gaps which are there, how prepared we are in terms of providing emergency services. Do the emergency departments have the complete list of the medicines which are required for managing any emergency? If, as I've mentioned earlier, that the trauma in the emergency services, people, they usually bifurcate that thing. Now we have to talk in sync with both the departments. Now, if you look at the health-seeking behavior, hello, sir. If you look at the health-seeking behavior, see, at an emergency in a public facility, this is all from the NITI study. You see the caseload which is there. Whatever caseload is coming in the emergency department, On an annual basis, this is 19 to 36% at any period of time. Medical legal cases also contribute around 7%. Then violence is also reported by care seekers as well as the healthcare providers. Then patient satisfaction is roughly 45%. We see that the services currently which we are providing, are we able to provide a set of services which are envisaged to be provided? Or are we providing services which are at least leading to the satisfaction of the patients or not? It's only 45%. We have to at least see that at least 75%, 80% of our beneficiaries, they are satisfied with the services we are providing. Then need for integrated emergency and trauma services, as I mentioned earlier, it will aid us in achieving the sustainable development goal. So these are the sustainable development targets. You see that how many targets it will be impacting if we are able to invest into the emergency. And there are many initiatives that the government is taking. One is everybody is aware about the National Program for Prevention and Management of Trauma and Burn Injuries. Then the PM Abhim scheme is there. A lot of investment has happened post COVID. Apart from PM Abhim, we do have funds for infrastructure development in NHM as well as the 15 Finance Commission. So a lot of focus is on development of infrastructure, but the challenge lies in how to integrate and make it a cohesive unit so that emergency and trauma care services are there. Then the national ambulance services we have evolved. In the public sector, we have tried to address the density issues. But apart from the public sector, we do have ambulances in the private sector. We have to see that how we make a system which is both private and government. They have to be in sync. There has to be one command center. Irrespective of whether it's a public ambulance or private ambulance, can we envisage that kind of thing? That's a challenge which is ahead of us. In addition, a number of initiatives aimed at building capacities of human resources and set of norms for public facilities. We do have that kind of mechanisms are in place, but they are all in silos, and somebody needs to stitch all this thing together and make it a comprehensive scheme. But the important thing is we do have opportunities. The National Medical Commission has given notification saying that any new medical colleges which are open, they should be having an emergency medical department. Previously, it used to be named as casualty department. Now it's emergency medical department. That kind of shift has happened in the thought process at the level. Now, all the old medical colleges, they are encouraged to start a emergency medical department. That kind of initiative there. Second opportunity which is available is the release of the IPHS guidelines, which provides norm for emergency care beds, HR infrastructure, equipments for emergency department in the district hospitals. To aid the implementation of this IPHS guideline, the release of today's guideline is a step in that direction. So what is required when we are planning for planning for emergency care? First, we have to find out what is the estimated number of emergency we may receive in a population of 20 lakh. That's a reference population, because if we, on an average, our district is ranging from 15 lakhs to 50 lakhs. But on our average, we are taking as a reference value of 20 lakhs. For 20 lakh population, assuming that 15% of the total population will require emergency care, that means it translates to around 820 persons need per day would be requiring emergency care. And 10% of this 820 may require constant monitoring to ICU and STU care. So in this way, you can plan the emergency care. If suppose you are heading a district of 50 lakhs, in the case of UP and other states, so you have to plan accordingly 15% of 50 lakhs, how it translates to the need per day and how it translates to need for ICU and STUs. And based on that, you can always factor that, and the IPHS 22 guidelines are there to help the states in planning that thing. And what are the principles which are required for planning emergency care in the public facilities? it's not restricted to only public facilities. If the private facilities also, if they want, they can also adopt these principles. It's not only sacrosanct that only public facilities would be there. These are guidelines which are available. It can be adopted into the private settings also. One is the golden hour things. When during the panel discussion, during the first panel and the second panel, when the first panel is discussing on the ecosystem and the second panel discussing on the transformation, you will understand the importance of the golden hour. Then the patient flow in the emergency department. The neonatal emergency, there has to be a separate provision for neonatal emergency and the obstetric emergencies. Then the fourth, the flow is you should have a definitive care in that particular institution. What kind of care you are able to provide at that particular facility. Then the other important aspect is the fifth most important aspect is you should be having a close linkage with critical care areas, laboratory and radiological services. The linkage with the other institutions, close linkage with the other institutions is very crucial because not all services are available at one particular institution. You should know which kind of services are available nearby, how you can tie up, how you can send it. The other day I was discussing with one of the panelists. He was saying that a proper referral linkage is required. And how that proper referral linkage is required and how we can translate that into reality, that's a challenge we have to work. Because during the COVID times also, we have started the emergency helplines, the telemedicine through teleconsultation, we were helping the patient. The moment some emergency was detected, but we were not able to provide the continuum and not able to connect with an institution so that a bed is being made arranged to them. And that's a challenge in seeing that for any emergency flow, we have to see that how we address this challenge. Then the IPHS, revised IPHS envisages that around the clock emergency operative clinical critical care is available. There is a demarcated triage area, emergency department with adequate space, dedicated. These are all the things which are given in this. Then all gaps which have been identified in the AIM study commissioned by Niti Aayog, they have been acknowledged and incorporated under IPHS 22 guidelines. And Dr. Venkat is there, so he would be saying after going through the guidelines whether these have been incorporated or not. You have to vet it, sir. Then the policy for triage which has been envisaged, that means you would be having red zone, yellow zone, and the green zones. So these are all been listed out. When one is planning for emergency department, you have to always factor all these things. What is meant by red zone, what is meant by yellow zone, what is meant by this. This kind of provisioning and proportions are to be made when we are planning a emergency department. Apart from that, various algorithms are there. 29 algorithms have been given in this district level guidelines, right from GI to the epileptic seizures. So these are the guidelines which have been provided in this. Then this is a diagram depicting the patient flow, how the patient will be received and how the patient will flow out of the after recovery. This is the diagram. And then another important thing when we are planning for emergency thing is we have to see that how the access of care is being provided to the patient, right from the ambulance triages to the inpatient wards. After the emergency, he has to go to the patient and he has to be discharged, or he would be shifted to the mortuary. That kind of flow is to be planned when we are having access to all these facilities are to be planned. The entrance area should have a easy ambulance approach and rapid access to all essential areas. One of the important things with the fire incident which has happened in the Directorate of Health, Madhya Pradesh, we have to all find out. In the morning also, I asked my team member, we see that are our public health institution fire compliant or not? That we have to find it out. One of the important thing is even in the NABH accredited hospitals, the access to the ambulance is not there in the private, but still they are having, because fire license is first and the foremost thing required for the NABH certification. In the private sector also, I found that ambulance can't reach there, but still they are having NABH certification. I don't know how it happens, because fire safety is going to be one of the major challenges in the coming years. We see that how we make it happen in planning and emergency department, because lot of instruments and other equipments are going to be pressed into service. And if the building is not fire compliant, then another aspect is that we have to see that how we make our institution fire complex. Then in this guideline, we have also given guidelines for what kind of number of beds are required in particular zone, red zone, how many beds would be required if for a district hospital of 50 beds, for a district hospital of 100 beds, how many beds would be required in pediatrics, how many beds in isolation, how many beds in yellow zone. That kind of thing is there. The IPHS 22 has provisions for the addition of beds during the time of emergency and disaster. As the climate is changing and we can anticipate natural calamities because of climate change and other things. And this IPHS provides provisions to see that how an emergency beds can be increased during the time of calamities. The states can propose additional beds depending on disease burden programs in this. If the bed occupancy is more than 70%, they can think of having more provisions of beds. Then we have also mentioned about, for planning purpose, we have also mentioned about the human resources for all the facilities that is there. I'm not going to the details of that, but for planning purpose, the details are also been given. What kind of human resources will be required. These are all guiding principles, but based on the requirements, based on the need. If the state is having a different kind of disease burden, so they can proportion or they can modify the requirements accordingly. Then one of the important things which has happened is the capacity building. We do have NELS for this, and lot of courses are also been run. There are other associations which do have this capacity building programs. But from wherever things are happening, our system should be resilient and should be ready to receive the emergency patient and provide prompt treatment. So the core team should be at least trained as in the essential. These are all the things which are given. But the essential is that we should have capacities. Creation of facility is one thing. Creation of capacity and then execution and delivery of the services is the next step which we have to always factor in. Then we have also given a layout or design how the emergency department or the emergency services should look like. So these are all indicated, but essentially the bottom line is that this kind of things are there based on the space requirement. The hospital planning architect and other things, they can customize this as per the available space and other thing. But these are essentially this functionality and other things as envisaged in the diagram. At least that was met. So this is all about this thing. Thank you very much for this opportunity to share my thoughts. Thank you.
Thank you, sir. Now, after setting the stage, I would now request my colleague, Dr. Kalpana Pavalia, to kindly moderate the session for the panel discussion 1 on the theme of emergency care ecosystems.
So good morning all. First of all, I would like to welcome each and everyone who is present physically here, as well as all our online participants. I'm Dr. Kalpana. I am the moderator of the first panel discussion session. So I would like to invite first the chair of the session, Dr. Himanshu Bhushan sir, former advisor, Public Health Administration Division, NHSRC, and former DC, Ministry of Health and Family Welfare. Dr. Bhushan has a rich and wide experience in the field, both as a clinician and in the public health. So it will be good. Yeah, public health expert. He has been instrumental in framing many policy and guidelines, including the revised IPHS 2022, the PHMC, the 15 Finance Commission, the PM Abhim, and the very own this guideline, the emergency care guideline. In fact, he was the member secretary of this group. We welcome you, sir. The next, our co-chair for the session, Dr. Manas Pritam Roy, sir. So you are welcome, sir. Please, sir, you are welcome at the dais. Dr. Manas, he's been working with the ministry. He's Assistant Director General, DGHS, Ministry of Health and Family Welfare, and has been working with the ministry for more than 6 years. He has been part of various international forums and has authored articles related to international and national health. We welcome you, sir. Next in panel, we have Dr. Batra, sir, Dr. R.K. Batra, sir, former head of Department of Anesthesiology, AIMS, New Delhi. He has a number of, he has been a member of various committees at AIMS and National Medical Commission and Ministry of Health and Family Welfare. He's a special advisor at the National Board of Examination also. He has a very rich experience and has over more than 60 publications and paper presentations in the field. We welcome you, sir. Then our next expert, Dr. Vinitya Das, ma'am, former professor and head OBGY, KGMU Lucknow. She's a known face in the field of obs and gynae, and she has worked extensively with the ministry and with other stakeholders for getting a change, for bringing a policy change in the women health. She has served as a member in various ethical committees, and she has more than 150 publications. She has been a very instrumental in revising our curriculum, the latest CMOC, BMOC, and LSAS curriculum as well. We welcome you, ma'am. And next in line is Dr. Tej Prakasina, sir. We welcome you, sir. He's Associate Professor J Prakash Narayan, Apex Trauma Center, AIMS, New Delhi. He's like a lifeline of the emergency care guideline. He's a secretary of the International Council of Critical Emergency Sonography, and he is very much always involved in training of doctors and nurses across the country. Without his support, we would not have completed or finalized the emergency care guideline. We welcome you, sir. And yes, our very next panelist and expert, Mr. Ajit Kumar Singh, sir, state lead path. He has been a very proactive and very instrumental in framing various policies and related to public health policies and the guidelines related to public health. He has more than 2 decades of experience in the field of public health, spanning transdisciplinary approach. His connect with the community, starting from the community to the tertiary secondary care level, is very prominent. We welcome you, sir. So this will be I welcome all the panelists and all the chair and co-chair for the session. So before starting with the first panel discussion, sir, I will just brief upon the topic. The topic of the session is, as you must be knowing, it is emergency care ecosystem. So as the name suggests, now that the guidelines have been released and we have finalized the guidelines, and now it is time that we need to stress upon how these guidelines and these services have to be implemented at the state and the district level. So if we are talking about the emergency care ecosystem, it starts from the bystanders to the service providers who are providing services at the district hospital level. It starts from the community at the primary level to the till the secondary care level at which the services will have to be provided. So the objective of the session would be to understand the existing emergency eco care system which is prevalent in the country, which involves the 3 pillars, that is at the site, at the transit, the facility provided during the referral time, and at the facility level, the emergency care which is provided at the facility. And to recognize the challenges which are present during this time, during all these pillars of the emergency care, and to understand the role of Center of Excellences and the medical colleges, what knowledge and learnings we can get when these institutions are involved, we'll get to know about from this session. And very not to forget the new initiative which have been recently launched. What can be the role of these initiatives? So before starting the session, sir, I would request the chair of the session, Dr. Bhushan sir, to please start with his opening remark and just throw light upon the topic and give a brief of the topic on the overall the theme of the session.
Thank you, Dr. Kalpana, for a very good moderation and also the setting the tone for the this panel's discussion. At the outset, I would like to thank NHSRC, ED NHSRC, the advisor PHA, and ministry also for giving me this opportunity to chair this very, very important, session. So, when we initiated the work on emergency care, what we observed, I had the privilege to visit more than 500 districts in the country during my tenure, either in the ministry or NHSRC. And the findings which were shown by the AIMS study, that is what we actually observed, physically. That is what we observed physically also, that the assured emergency care is widely lacking in the states, and particularly the district hospitals being the epicenter of the, of a district. It must provide the assured care. And from there, the beginning of the journey started for this emergency care. But in the meantime, the primary care came a big way, and we ministry decided that let us have the primary care guideline. So the primary care guideline is already launched. Dr. Bala was here only just now, and he was the pivotal for all the training capacity, where the focus is more on the preventive promotive care. It's not only the A&M, it is not only the ASAs and the doctors, but also the family, the community, because the role of the family and community is equally important. If somebody is going out from your house on a bike or motorcycle, then the family must insist that you must wear the helmet. Otherwise, you may suffer injuries. The seat belts while driving the car. And you will be surprised to know the accident, death and severe injuries just because not wearing of the seat belt. It's a huge percentage. So these are small things, but it has the role of the family and the community. So primary care guidelines addressed all these things, and also it addressed the timely, how to recognize, timely emergency. This is very, very important. At the site of the accident, or when the patients are brought in the hospital, the timely referral, because the referral was discussed by advisor PHA also, and then after doing the initial resuscitation, you refer to a proper place. But that proper place, where is that proper place? That proper place is still lacking in the states if we talk of from our core of the heart. And that proper place first will be any hospital providing secondary care services, be it district hospital, SDH, or the FRU, CHC. And this guideline is going to exactly help the states in providing that ecosystem where you need to identify the HR, you need to build the capacity of the HR, the drugs, the equipments, how to try it. You might not have the space, because district hospitals have been created long back, and they might not have the same infrastructure which the guidelines says. But at least you should have, even if you have the 2 beds, there should be 1 triage bed, so that you can save the life immediately. You should have critical care monitoring beds. And then, as Joint Secretary said rightly, that is envisaged that the critical care blocks which are coming in the district needs to be nearer to the or adjacent to the emergency, so that even if you do not have the space in the existing emergency of the district hospital, you can shift the patient to the critical care, and during peace time, all the critical care blocks could be utilized. So how to utilize this cycle? We are of the belief that 90% of the emergencies can be tackled in the secondary care facility, either at CSC, FRU, or district hospital, or SDH. And only 10% should go, or 15% should go to the tertiary care for super specialty care. Mostly super specialty or very complicated, emergencies or life-saving, things. But that is not happening at present. The tertiary cares are overburdened. How will you utilize tertiary care? There are the faculty here, present here, and they are also there in your states. But how would you identify a center of excellence or a medical college to support some of your districts, to support to build the capacity of your staff? Every state, when we go, they talk about the HR, human resource, first. But what I would like to request to the state, that first of all, try to have that flow, that infrastructure, the drugs, the equipments, those beds, your paramedical staff, your nurses staff, triage nurse. That is the more important than the doctor first. And the specialist, if you don't have, the emergency medicine, you have the anesthetist, don't have anesthetist, then you have the medical specialist or a surgical specialist, and MBBS doctors. Utilize MBBS doctors, build their capacity so that they can man your emergency round the clock. So this whole ecosystem is to be operationalized by you. But sir, the first and foremost thing which is required for this is the commitment of the state. I will cite the example of Tamil Nadu. Tamil Nadu has, the commitment was there in Tamil Nadu, and you see the emergency care in Tamil Nadu. It is assured emergency care in Tamil Nadu. Just because the state's commitment was there, the bureaucrats' commitment was there, and the technical people were committed. But is there any other state? So, sir, this is the opportunity, particularly for the states. I would like to request that the whole ecosystem is there to support you. The panel, these experts, the medical college, there might be only 5 or 10 here, but this indicates the commitment of the medical college to support you. But you should have the equal commitment to utilize this resource so that you can build this ecosystem for assured critical care. And the last line which I would like to convey to you is that out-of-pocket expenses, if we talk of, everybody says drugs, diagnostics, I agree. But the third biggest pillar of the out-of-pocket expense is if you do not give the assured emergency care at your public health facilities. Every day I receive 10 calls. Even at Delhi, I am helpless. I am not able to give and to send which hospital, where, because all these are referral from your nearby states. This clearly indicates that our states do not have this, the assured emergency care. We have Dr. Khasnovis here, so who has already created NEL centers. Are we utilizing the NEL centers? I can name the states that the fund has gone, but the work has not been initiated. I am not naming. So, sir, for all the states participants, my humble request will be, and to this August gathering, that unless there is a commitment, resources are not bottleneck for you. The IPHS commitment is there, 50% IPHS the states have to undertake. So please initiate this work. Funds will be there. This team is there from NHSRC, and the experts are there to guide you. But your ecosystem, you have to utilize. And I will request now our co-chair and other panelists to further dwell on this. Thank you so much.
Thank you, sir. Thank you so much, sir, just for setting the tone of the theme. And I would now request our co-chair for the session, Dr. Manasa, to give his introductory remark on the topic, sir.
So, respected chair, sir, senior officers from Ministry of Health and Family Welfare, and teaching institutes and partner agencies, and other delegates. So I would like to first thank the organizers for considering me for this gathering. So as Chair Dr. Bhushan sir was saying, that there are still lacks. So would like to put it upfront that we are not doing enough. That's why it's mid of 2023, and we are still considering making our secondary care hospitals functional for emergency care. And when you go through the agenda, nowhere it has been said that we are talking about road traffic injuries. It's not that. So when you talk about emergency care, it's not only about road traffic injuries. It's about ischemic heart diseases. It's about acute exacerbation of COPD. It's about drowning. It's about burn injuries. It's about everything that is being presented in an emergency hospital. So when we are sitting at the emergency hospital, we just can't say that, so see, this is a case of road traffic injury, so I'll treat this. That's a kind of heart attack, and I'm not going to have a look at them. We don't have that luxury. So when we are talking about emergency care, we understand that road traffic injuries are often misinterpreted as the only representative of emergency. It's not that. We are also talking about heart attacks. We are also talking about stroke. We are also talking about acute exacerbation of COPD. So from that point of view, and we are talking about secondary hospital, district hospitals. So there are still miles to go. So you see, if you go through the publication from ICMR and IHME, that is based on global burden of disease study, you will find that ischemic heart disease is contributing almost 7 times than the road traffic injuries. So when you say that we are dealing only with an audience of only with a workload of say or 5 lakh deaths, 5 lakh road injuries and 1.5 lakh deaths in our country. In emergency, it's not that. So probably we are dealing with a much more higher number that we are actually mentioning here. And if you consider that difference in the healthcare system in different parts of the country, and there is still much difference between different countries. See, sir was talking about Tamil Nadu. So Tamil Nadu in 2016 or 17, there was almost 17,000 deaths due to road traffic injuries in a year. From that, in past 7 years, they have halved. Right now, it is somewhere around 8,000. So they have successfully reduced it by 50%. But still, if you compare different states in terms of road traffic injury, Tamil Nadu is one of the toppers. It's at number 4 or 5. So what we mean to say that we do have still ample scopes for improvement. So in the inaugural session, we are discussing about ambulance services. We are comparing about our ambulance services with that of UK and US. But a recent publication from ACE that was conducted in Faridabad, if you go through it, you will find that less than 3% people, they are actually using ambulances. So whatever comparison we are drawing, it's about 3% of the patients that are being taken to the emergency department. Rest of the people, so God knows by which method, by which way they are reaching hospitals. Their own car, someone hired a car, again, incurring out of the pocket expenditure, as Dr. Bhushan sir was saying. So still we are not being able to provide a way of systemic referral services to our population. We're still lagging much behind. So we conducted one study in Safdarjung. We're talking about Delhi, the capital of this country. So only 10% of the people, they were using ambulances. The rest of the 90%, they didn't have any clue that how to reach their hospital. And many a times they are just running from post to pillar, from one hospital, well, no service is available here.